the burden off of the primary care physician. But because this is such an intensive program, it really couldn't be offered to all of the diabetics. And the truth is that most diabetics, between the interventions from their primary care physician, their diabetic classes, and potentially seeing an endocrinologist, will get into adequate control. But there is a certain population that, even with all of those interventions, still don't get their blood sugars down and their other measurements under control. And they frequently have some specific barrier to themselves. Either there's psychosocial issues or some other things that they need, potentially more support that the primary care physician doesn't have the time in these busy days to provide for them, that this team could supply. So now I'm going to turn it over to Dr. Andrea DeCoro, Director of Clinical Services, to talk about the role of each of the members of the team.
So the Active Diabetes program was really designed to provide individualized care for poorly controlled diabetic patients. And I'm going to discuss the roles of the team members because it's important to understand how they interact. There's really areas of overlap, and then the team was also assembled from staff from two separate entities. Greater Newport Physicians supplied part of the staff, and Hoag Hospital supplied the other part of the team. So I'll start off with the role of the clinical pharmacist. The clinical pharmacist's responsibility was to manage the medication as it relates to the diabetes care. So anything to do with anti-diabetics, anti-hypertensives, or anti-hyperlipidemics. That includes initiating therapy, stopping therapy, and ordering labs. And that doesn't mean to say that that was the only thing that was considered, but that's based upon collaborative agreements with primary care physicians, but they had the autonomy to adjust on their own. But all of this was really done in conjunction with the primary care physicians and the endocrinologists, if there was an endocrinologist involved with the case, and a lot of times there was. And so the role of the clinical pharmacist was also to provide a unique perspective by virtue of their training and to be able to identify any obstacles or barriers the patients may have to their medication therapy. So case in point, there were a few patients that needed to start insulin therapy. Everybody involved with the care of the patient agreed that would definitely be the next step in order to control the patient's blood sugar, but the patient was completely resistant, and it wasn't because they were afraid of needles. They just didn't think they were sick enough to require insulin, or they had a family member that had diabetes and had an amputation, so that meant that they were next in line for that outcome. But really taking the time to educate the patient and explain that the medication therapy is really meant to prevent those negative outcomes, allows the patient to buy in and become accountable and really become under better control. And so we know that time is really important, and we recognize that primary care physicians don't have an hour initial visit to spend with the patient, but this is what we allowed the clinical pharmacist in terms of time for time to help the patient with their medication management. And that time could be an hour or more ongoing. So now on to the medical social worker. The medical social worker really operates on the premise of planting or preparing the soil and then planting the seed. And what I mean by that is she immediately addresses the patient's feelings about diabetes and tells them that they are not diabetes, they have diabetes, but it should not define them. She immediately identifies and addresses the patient's barriers. They're coming from different places. They could be angry about the diagnosis, they could be in denial, or they could just be completely overwhelmed by the burden and how much it takes to be a diabetic. There's a lot of time and energy spent up front in terms of self-care and goal setting. Maybe start with goals that the patients can achieve, let the patients pick their own goal, but always strive to increase and improve the goals. Each patient undergoes depression screening, and if patient tests positive for depression, the primary care physician is contacted, and the patient can either be referred back to the primary care physician to address that or to behavioral health, if that's what the primary care physician prefers. And then repeat all of the above over and over. And finally, nothing says I care about you more than a call on your birthday, so there's definitely a human component to her interaction with the patient. So now we have our dietitian whose role is to educate the patient on how to adhere to a healthy diet. The dietitian takes a complete history and works hard to understand where the patient is at that point in time in their life. Are they working a lot of hours? Do they have family support? Do they have a cultural stigma? So on. That needs to be worked through. And what visit to a dietitian wouldn't end with a discussion on your weight? So the dietitian will help you set goals, be a coach, and sometimes even refer you to the community programs. We also have a nurse practitioner whose role really was to perform an extensive history and physical, and from that assessment to meet with the team members in form of a team huddle prior to the rest of the team seeing the patient. All field exams are done by the nurse practitioner and referrals to podiatry as needed. Patients that need a retinal eye exam will receive a retinal eye exam. The Hoag, Dick and Mary Allen Diabetes Center actually purchased a retinal camera, so it makes it easy. Patients right there. And those results are sent to a contracted ophthalmologist, and then that is actually put into the EMR seamlessly, and she will refer as needed. And so finally, we believe that the success of the program is because it's a coordinated, structured team, and that the goal of the team is to really be an extension to enhance the already good care that the patients are receiving from the primary care physicians. And so now I'm going to turn it back over to Dr. Solomon to quickly go through our results.
So that's the care team, and the question is which of the patients that that were being enrolled in the program. The initial criteria, and the belief was that these should be the most complex, difficult to control patients. And so the initial entry criteria were an A1C that was 9 or above, and the patient was continuing to struggle with diabetic control. And these patients, as was mentioned earlier, could, and for the most part, were already referred to the endocrinologist who became part of the care team if that was the case. The initial enrollment was somewhat slow because the criteria were high and there were only a few patients that could enroll. But as the patients started to go through the program and get back to their primary care physician, the primary care physicians were very happy to see that they were spending less time doing some of the basic education and some of the adjustments that they had been doing, so they became happy with the program. And all of the patients going through the program were asked what about their satisfaction with the members of the team. Oh, I forgot to mention, definition of struggling to manage diabetes. If they were they persistently elevated A1C, if the physician noted that they needed some kind of individualized education on their diet or exercise or management of their medications, if they had a complex drug regimen or were having side effects, or some other psychosocial barriers. So this was the satisfaction, this is the satisfaction results from the patients for each of the members of the team. You can see it's very high. And so as the physicians were very happy with the way the results were coming back, and the patients started to tell their friends and family about how great the program was, we got more and more pressure to liberalize the entry criteria. So we generously lowered the A1C to 8, which did increase the number of patients that were able to be enrolled. And we started to actually get patients who were newly diagnosed with diabetes, or perhaps had an A1C in the mid-8s, but were maximizing the oral medications and needed to transition to insulin and really weren't ready to do that, or some patients who hadn't seen the endocrinologist yet. And so this is a graph depicting the initial data for all of the patients that were enrolled into the program up through this past summer. You can see that 30% of the patients had an A1C already below 9, and that was because we had liberalized the entry criteria, but that still means that 70% of the patients had an A1C above 9. Only 2% were below 8. And the other thing we found is that our physicians were doing a pretty good job on managing blood pressure and a decent job on their LDL goal at the same time. So what I'd like to show you is after the patients had been enrolled into the program, and some of the patients would graduate, some of the patients would be in a little bit longer, what were the results on their final results of these same data sets, given that these patients had to have been in for at least 3 months for a subsequent data set. And this is what we got. So as you can see, over 80% of the patients now have an A1C below 9 and 63% below 8. And even though the blood pressure and cholesterol control was pretty good to begin with, we actually had significant improvement there as well. So when we compare that to the IHA 90th percentile goals, we actually hit 3 of them quite well. So I told you this was a little bit of a journey. The initial grant was supposed to be a 1-year grant, and through some good fiscal management, we were able to eke that out quite a bit longer than that, but the grant is pretty much over at this point. In addition, as mentioned at the beginning, Greater Newport announced their affiliation with Memorial Care. And so for those reasons, plus a few other ones, Hoag Hospital has withdrawn from the program, so we've lost our retinal camera nurse practitioner and dietitian. So right now, the program for the last few months has been run with our clinical pharmacist and our clinical social worker. And it's given us an opportunity to really think what are the components that can continue to provide this kind of result for our patients. The retinal camera actually turns out it was very nice to have, but the patients are still, because the primary care physician is such an integral part of the team, has been very good at referring patients to the ophthalmologist for an exam. And the other part of the clinical exam and the referral process, again, the primary care physician has been doing it. And so even though normally a nurse practitioner is a very integral part to any kind of clinical team, in this case, we're not sure we actually need to have the nurse practitioner there. The role of the dietitian, on the other hand, really isn't filled by the current team members and probably does need to be replaced. The other thing we're going to implement is the medical assistant, as part of the vital signs, can do the monofilament exam as it is an objective test, right along with doing the vital signs when the patients are checked into the room. So now you've heard about our experience with implementing and running the program, as well as the results. But at this point, we'd like to let you hear from one of our patients on his experience, one of the first patients actually, with his experience in the program.
I was always thirsty, so I went into my primary care physician and she ran a test on me, and that's how I was diagnosed. And I actually made him take the test a second time because I didn't believe him. My name is Mike Fujimori. I'm 52 years old and I have type 2 diabetes. What I realized early on, and as I progressed with this disease, was that if there was no me, then there was nobody here to take care of my wife with multiple sclerosis. There was no me to take care of my 2 teenage boys. That was the motivating factor. I was referred to the active diabetes management program through my primary care physician. Honestly, today where I'm at with my diabetes, if I hadn't have gone in the program, I probably would be minus my leg.
Through population health management, we are creating disease management programs like the Active Diabetes Program, which will improve health outcomes for the patients of Memorial Care Medical Foundation and the communities that we serve. When Mike first came to us, he really was kind of lost. Wasn't really sure what he could do to improve his diabetes and to improve his sugar control. So we had to work with his medications and find a plan that would really help him manage his diabetes in a way that was adjustable to his lifestyle.
Greater Newport Physicians' Active Diabetes Program is unique in that it tailors treatment towards the individual patient. It allows them to come in and get one-on-one, hands-on care from specialists that coordinate closely with their primary care physician so that we can kind of get everyone on board and get everything under control.
With the program, I never felt that I was being judged for being either a good or a bad diabetic. They came to my side and helped coach me. When I got into the program, I was at an AC1 of 10. Currently, I'm at 7, and I've been at 7 for 2 years.
But just having that extra intervention, the extra hands-on care has just allowed him to be able to manage his diabetes much more effectively.
In my heart, I believe, if I can equate this to one of my passions is fishing. You don't catch all fish with the same bait. There's not one specific treatment. It has to have a personalized touch. Not only am I on a journey, but I have the GMP program with me, monitoring what it is that I need to do to better my situation with my diabetes. It has made my quality of life 120 times better than what it would have been.
You can't catch all fish with the same bait. That was, we couldn't have said it better ourselves. That was really the goal of the program, to recognize that a certain population of patients really need individually tailored care. And that's what we've provided, and I think the results show. Thank you. Thank you.
Thank you.
Questions or just sitting?
Yeah. Actually, if you wanted to take 1 or 2 questions from the audience, we can have them now. Questions?